Welcome to the Explainer. Okay, let's dive right into this. When most people think about methamphetamine use, they immediately picture it as just a simple behavioral issue, right? Like bad choices leading to bad outcomes. But today we're going to completely reframe that. We are going to look at meth-induced paranoia not as a moral failing or some kind of personality flaw, but as a severe, fascinating, and highly specific mechanical failure of the human brain. We're going to literally look under the hood to see exactly what happens when the brain's delicate machinery just gets completely hijacked. Here's our roadmap for today. First, the reality of suspicion. Second, the dopamine connection. Third, hijacking the brain. Fourth, the sleep deprivation multiplier. And finally, clinical realities and treatment. We're basically going to use a zoom-in, zoom-out approach here, going from outward observable behaviors right down into microscopic brain chemistry and then zooming back out to real-world clinical care. Section 1, the reality of suspicion. Because to really grasp that internal chemistry, we've got to first recognize the stark, real-world symptoms that families and clinicians see every single day.
These behavioral signs, they almost read like a script from a true crime documentary, honestly. You've got individuals repeatedly peeking through curtains, utterly convinced their phones are tapped, or even accusing their closest family members of these wild, elaborate conspiracies. You'll often see extreme social withdrawal, or people actually carrying weapons for quote-unquote protection. And it is absolutely crucial to understand, right off the bat, that carrying those weapons or accusing loved ones, those aren't malicious, calculated choices. They are symptoms. They're the outward manifestation of a deeply, deeply distorted threat perception that's actively happening inside the brain.
So, clinically speaking, paranoia is an irrational, persistent feeling that others intend harm, marked by extreme hypervigilance. Now, what's really interesting about this strict clinical definition is that the brain is actively misinterpreting completely neutral, everyday events, like a car driving down the street or a friend's just sending a text message, and it's processing them as immediate, life-threatening dangers.
Section 2, the dopamine connection. Let's shift from those outward macro behaviors down to the microneurological level, zooming right into the engine of the brain to see what's causing this.
Methamphetamine is a profoundly powerful central nervous system stimulant. When it enters the body, it doesn't just tap on the brain's chemistry, it completely floods it. It drastically spikes norepinephrine, serotonin, and primarily dopamine. Now, in the very short term, sure, this produces intense alertness, energy, and euphoria. But the dangerous, long-term reality here is that it floods the brain's mesolimbic pathway, which is our core reward and emotional circuit, with an entirely unsustainable, toxic amount of dopamine.
And this brilliantly illustrates the connection when we compare the exact consequences of that flood to severe psychiatric illnesses, like schizophrenia. The chemical mechanisms are strikingly, almost identically similar. In both cases, this massive excess of dopamine fundamentally distorts how the brain perceives threats. The brain's threat detection system starts assigning profound, terrifying false meaning to totally ordinary events. This chemical mechanism of false meaning is exactly why the two conditions look so incredibly similar from the outside.
And just look at how common this actually is. Up to 60% of chronic meth users experience meth-induced psychosis. That is a staggering statistic. Well over half of chronic users will experience severe symptoms like auditory hallucinations, literally hearing voices that just aren't there, and intense delusions of persecution. This is not some rare, one-off side effect. It's a primary feature of chronic use.
Moving to Section 3, hijacking the brain. We are now going to map out exactly which physical structures in the brain are being damaged by this massive dopamine flood.
To really get this, I like to use the false alarm metaphor. Let's look at the amygdala first. That's your brain's fear and threat detection center. Under the influence of meth, the amygdala becomes massively overactive. It is essentially pulling the fire alarm and screaming threat, danger, nonstop. Now, normally, your prefrontal cortex, which is your logic and judgment center, would step in, take a look around, and say, actually, there's no fire, guys, we're perfectly safe. But meth damages the prefrontal cortex, resulting in incredibly poor reality testing. The logic center is literally offline. Meanwhile, the striatum, which handles dopamine control, gets completely overloaded and actually starts forming these complex delusions just to explain why the fear alarm keeps going off.
The result, the user feels constantly threatened even when safe. I want to just pause for a second and let the empathy of that statement really sink in, because the logic center is broken and the fear center is screaming. To the user, these terrifying delusions feel 100% physically and emotionally real. They're experiencing genuine, absolute terror, even if they're just sitting in a completely quiet, safe room.
Section 4, the sleep deprivation multiplier. I want you to imagine the structural brain damage and chemical chaos we literally just mapped out. and then add another massive biological stressor right on top of it.
Because methamphetamine is such a powerful stimulant, users frequently stay awake for days at a time. And we know from sleep science that severe sleep deprivation all on its own, like even if someone is completely sober without any drugs involved at all, can cause paranoia, profound irritability, and actual hallucinations. The human brain simply cannot function without sleep.
So the crucial point is right here. You take the neurochemical chaos of methamphetamine and you add the massive biological strain of severe sleep deprivation. Lack of sleep acts as an immense force multiplier. It's basically pouring gasoline on the fire, accelerating the brain's journey past simple anxiety and straight into full-blown, magnified paranoid psychosis.
Section 5. Clinical Realities and Treatment. Let's zoom back out to the macro level to discuss the sobering reality of what happens when the drug use finally stops.
How do rehabs and psychiatric facilities actually manage this intense crisis? Well, keep this number in mind, 11. Clinical research shows that meth users are an astounding 11 times more likely to develop psychosis compared to the general population. 11 times! That number permanently cements the immense, undeniable psychiatric risk associated with this specific drug.
And a major reason for that risk is chronic neurotoxicity. The danger doesn't just, magically vanish the moment the drug leaves the bloodstream. Meth causes long-term dopamine receptor damage and actual structural changes to the brain. This leaves individuals highly persistently vulnerable to chronic paranoid disorders for months after they stop using. And research shows this risk sharply increases based on the dose, how long they used it, and if the drug was smoked or injected.
Let's move to the actual treatment protocols and see how this builds step by step for professionals. Step 1 is absolutely critical. Do not confront the delusion directly. Why? Well, because as we learned, their prefrontal cortex, their logic center, is chemically broken. Arguing logic with a broken logic center never works, it only increases their fear. Next, you have to provide a very low stimulus environment to calm that screaming amygdala. Then, ensure massive sleep restoration to remove that sleep deprivation multiplier. From there, clinicians might use antipsychotic medications during detox to help regulate that crazy dopamine flood. And it's only after they are neurologically stabilized that they begin cognitive behavioral therapy, or CBT, to slowly, carefully rebuild that damaged reality testing.
So, I want to leave you with this question to really chew on. If meth-induced paranoia is a measurable chemical and structural brain disorder, how should that change the way we view and treat severe addiction? When we shift our perspective from viewing addiction merely as a behavioral failing and start actually treating it as the profound neurochemical injury it is, it changes everything about our approach, our empathy, and our clinical care. Thank you so much for joining me to unpack this complex topic today. I really hope this explainer gave you a totally new lens through which to view this issue. Keep questioning, keep learning, and I'll catch you in the next one.